So it's my pleasure today to introduce Dr. Soha Ahmed, the head of clinical oncology at Aswan University in Egypt. Soha is a dear friend of mine, and she is one of the most motivated radiation oncologists that I've met, working not just to help her center, but any other center that she can meet. And she's so friendly and kind-hearted, and she has lots of good experience with breast cancer treatment. And I think today she's going to give a great presentation on contouring training cases to help your center transition to 3D treatments for breast cancer. So without further ado, Soha, I'll let you take it away.
Thank you so much, Ben. Hello, everybody. I'm happy to be with you and continue with our course, hoping that you're enjoying the lectures past and today and the upcoming, and hoping that this carry out a fruitful benefit for you and helping you to improve the practice of radiotherapy in your countries. And also happy of this networking and knowing each other and asking each other for any help, any further informations. I'm always happy to be with you in this course, really. I enjoyed a lot. So coming from Egypt, where we have this central, unbelievable part of the earth in the middle of the world, here is Aswan, and this is Luxor. This is southern Egypt, and Dal Ahramat طبعا وأبو الهول. This is nice Alexandria. It was shooted by myself in the last conference in Alexandria. This is the Red Sea area, and this is Siwa Oasis in the east part of Egypt. So I would recommend when the COVID is regressed, that everybody come and visit us and having fun in this nice country. So your feedback is very important. Today we are going to cover as much as we can the goal of the 3D breast planning and breast and lymph node contouring. We will go in deep, digging deep in this area, and also talking about the toxicity and late effect. And throughout all the lecture, we will go through how to avoid such a toxicity and how can we having a plan that we are not going to worry about the late effect in such cases. So this is my resources, of course, NCCN guideline for the clinical treatment and decision-making. And yesterday I shared with you the 3 available atlases of the breast, hoping that you have a look. Of course, the residences know them much perfect than me, RTOG and RADCOM, and recently the Estro atlases. Today we are going to discuss what's the differences and why we have those different atlases in the context of breast delineation. And regarding the treatment planning, we have plenty of handbooks. I know that you have a plenty on your drive, books for planning and contouring. So pick the one who you feel that it is comfort for you. RTOG Atlas again, RAD-ONC. And today I'm going through the econtour.org because it's really useful and very friendly contour tool. And myself, I enjoyed a lot when I keep trained and when I'm preparing this lecture for you. So just to warm up and make sure that everybody is joining us, lessons from the past. I'm coming from Egypt, so the history is very important for me. So if you're going to have an idea about what's the evolution of radiotherapy strategies in breast cancer in the past, early studies of the breast radiation leads to standardized field and dose fractionation approaches for all patients, the whole breast 3D field to supraclav lymph node, post-mastectomy radiotherapy to the chest wall, and comprehensive nodes, 54 to 50 gray plus minus boost according to the risk stratification, conventional fractionation size 1.2 to up to 2 gray. So we passed through an era where one size fits all. And this was a standardized approach for all cases of breast cancer. Why that? Because lack of data regarding the variability of the breast cancer subtypes and the biology. And also the innovation of the technology nowadays was limited in those days, and to investigate a new technology. From 1970 to early millennium, we had a landmark studies. Everybody know them, and we just knowing them by heart during exams. B21, Danish study, B06 and B04. Those trials that help to standardize this concept of breast irradiation those days. By time, because time is improving everything, we developed of the early millennium to till now, 2020, recognition of the breast cancer subtypes and more knowledge about the biology and the immunology even, which give us the power to tailor the treatment based on the individual risk. Also, the huge technology innovation coming from CT simulation, planning, improving the dose, homogeneity, and target localization, widespread access to new techniques, including external beam partial breast irradiation. So here in early we had the first consensus paper of the partial breast irradiation in 2003. In 2004, we have the guideline on radiotherapy omission in low-risk patients, above 70 patients, and this was a very shooting trial that helps a lot for all people to omit radiotherapy. Coming back from 2002 till 2013, a series of hypofractionation papers from Canadian and UK start trials. 2015, we have the URTC and MA20, the role of regional lymph node, particularly the internal mammary lymph node, and the debate that it was the low-risk patients having 1 to 3 lymph node, should we radiate or not radiating? So this article was a good guide for such a cases. So in 2020, now we have tailored radiotherapy, and it's become a reality. We cannot accept one size fit others. Today, we are tailoring the radiotherapy upon risk and many other factors. But we have many questions remains. Can we expand the radiotherapy choices for low-risk patients? Nowadays, we have a trial that's talking about the de-escalation protocol for those low-risk patients, and how can we improve the outcome in high-risk patients. And while the overall outcomes have improved over the past decade, so the toxicity remaining an issue, because whenever you improve the overall survival, the people is alive, the people return back to their family, return back to their jobs and work. So they need to overcome the toxicity and late effects that could happen from their treatment. And outcomes remain poor for some high-risk patients, and this was an issue to elaborate more techniques and more boosting, and maybe join it with more advanced chemotherapy and changing the regimens in those particular high-risk patients. So I will move through two cases. The first one is early stage disease, and the other one is late stage breast cancer disease. And through those two cases, we are going to discuss the delineation of the breast and lymph node, and having all the tricks and things that you may help you in the contouring and delineation. So we have a 41-year-old woman presented with the 5mm area of calcification on a routine screening mammograms. Nowadays, many in our country, even the Middle East, have a mammogram, and there is not a low bunch of women that I see discovered by the screening itself. So they become a very good candidate for early stage disease, and they are responding very well. She had a corneal biopsy, shows high-grade DCIS, and then she undergo to lumpectomy, which shows 7mm focus of high-grade DCIS, and ER was negative. All margins are greater than 2mm. So she referred for consideration of adjuvant radiotherapy. And of course, we are going to radiate the only breast and no indication for lymph node in such a case. So if you're going to move through this simulation, we will mark out the clinical borders of the breast tissue. First, the patient is going to lie supine with customized immobilization device, as you know, the breast device, the breast holder. And we have, it's better to have the bilateral arm abducted and externally rotated. And we will put, like what you see in the picture here in the red color, a wire through all surgical scars, a wire all through the breast tissue, glandular tissue itself, and a wire for the surgical stars. And if there is any drain, I highlighted also with the wire. As you see, the target volume entire breast is using tangential field. In the upcoming slides, I will show you. Here is marks for the mid-axillary line, and here is the superior border, inferior border, and this is the midline wire, because we will recognize them while contouring in the case in the next slides. So take care about the angle of the patients on the upper torso, typically with a breast board, to decrease the sternal angle. This is the issue. We want to decrease the sternal angle of the patients when they are lying out on the breast board. But sometimes when you over-angulate the patients, you create by yourself some unwanted folds, particularly in pendulous breast. So just keep an eye when you are tilting your patient that the breast fold is not exaggerated, particularly the lateral side in the fatty pendulous breast, because this will cost you tilting of the lateral tange and more heart and lung volume to be irradiated.
Soha, one question on the last slide. Can you clarify what is meant by sternal angle?
Well, I need a lateral view. Yeah, I need a lateral view. If we have the supine, if you imagine this patient is lying in the supine position. Okay, so we have here angulation of the sternum. It's not straight forward. Okay, so when I make it lying with angle, let's say 45-degree, I straightening this angulation of the sternum and make it as flat as the board. You understand me? I have a normal angulation. I want to straighten it up. So I move the patients up in order just to straightening this angle. Okay. It will be clear if we have a lateral view.
Okay.
Okay.
Thank you.
Okay. So I will go through a couple of slides, then we will go to the e-contouring case. So here, as I told you, we are highlighting with the wire the breast tissue itself and the scar. So the CT breast, the whole glandular tissue that we feel, it's not clearly visible on planning CT. So we can determine it by our clinical sense of the breast tissue itself while in simulator. So this is very important for us to put the wire where the breast tissue that we can felt it already, because sometimes, depending on the age of the patients, the glandular breast tissue is not that clear. And also depending on the window of the CT and other factors. So it's important by yourself to wire and highlight the glandular tissue that you can feel it physically during the simulation. The problem in this case that there is no clear anatomical border visible except the dorsal side. We will see it in the CT now. So radioback wire, it's not a true border, but it will help a lot. Take visible breast tissue into account, include the visible surgical effects, and the nipple and area complex should be spared if possible for cosmetic reasons when we are going to irradiate the breast. And most local relapses occur close to the scar, so we have to make sure that the incision scar should be irradiated and well covered. Let us go to the for friends who didn't log in this site, econtouring.org. The breast, click whole breast. This is case 128.
Let's see, Soha, can you click share screen to do new share, and that way you're sharing your web browser?
You can see what I share now?
You need to click the green share screen button again. And now click on the window that shows the eContour.
Okay.
Okay, great. We all see it now.
Good, okay. So here is the website, econtouring.org. Here is the breast, whole breast case. You can find plenty of cases. I will click for the target. I will offline everything apart from, okay, here is the breast CTV. I can also having the organ at risk and offline everything. Okay, so here we go. So this is the breast CTV. If I'm going to move up the, okay. So this is the wire where we circulate the breast tissue. Here, this will make it very easy to go through the glandular tissue, even if it is not that clear, because the wire will guide me, never cross the sternum. And this is the midline. And this is the mid-axillary. Okay? Okay. And here is the scar wire. So I'm making sure that everything included in my CTV. So the CTV breast from the cranial, it's the sternoclavicular joint, as we see, and the caudal, the lowest side of the visible breast contour. Superficial is 0.5 centimeter of the skin, except for T4B, CD, we have to we have to find a way to boost the skin. Deep, we have the superficial side of the pectoralis muscle and the thoracic wall. So I will not go through those details. It's pretty much detailed in the atlases, because the edges and the contour details itself is pretty much informed in the atlas, because we have plenty of ticks. I want to take care of it.
Soha, can you click the green share screen again? And now this time, bring it back to the PowerPoint slide.
Sorry.
No worries.
You don't have...
Perfect.
Okay.
Great. This makes really good sense now, seeing it on the eContour, now seeing it on the slide. So thank you.
Yeah. Okay. So here is the breast CT, all apparent glandular tissue, limited anterior of 5 millimeter from the skin and posterior to the anterior surface of the chest wall, excluding the muscle and the bone, as we see here. And if you come to the breast BTV, we have the breast CTV plus 7 millimeter in 3D contouring. And of course, it is center variation. Some centers give one centimeter and other less. So this is a center variation. And this expansion excludes the heart and does not cross the midline. So we just want to make sure that when we have the PTV expansion, we shouldn't cross the midline in order not to encroach upon the contralateral breast when we are designing the tange, because the tange is coming from the side. So if you are crossing the part of the sternum, the tange will coming here and taking part of the other side of the breast, and also increasing the volume of the breast, of the heart and lungs. So take care very, very carefully about your middle edge to not to across the sternal edge from the side.
Dr. Soha, we have a
Yep.
question regarding the contouring the targets. Should we also contour the scar as a separate target to make sure it receives enough dose?
For me, I just keep an eye from the wire, but I'm not going to contour it. I'm not going to contour the scar itself. Just making sure that it's included on the breast tissue, because sometimes you have a different shape of the scars and in different locations. So, and this is important, particularly when you have a plan with which don't have a boost. So you have to make sure that the scar receiving a good dose from the whole breast tissue TENS treatment. But for me, I don't contour the scar. I just wire it, and making sure when contouring the glandular tissue itself that I have the scar in my PTV.
Okay, thank you. Does that help? Okay, great.
Okay. Any other question?
None for now. You can continue.
Okay. So we have what we call the breast PTV eval. Do you have it in UCSF, Ben?
I think so, but I'm not the breast expert.
Yeah, okay. So the PTV eval is not a common, term in our practice in Egypt, but we do it every day. But we don't know that the name is PTV eval. So the PTV eval, it's edited to acknowledge that it is very difficult to cover or deliver the full dose to the skin. So we designed it to, let's say, for the DVH analysis and constraints. It's not a clinical wise rather than analytical wise for the DVH evaluation and constraint. So what's the PTV eval in simple term? It's just what we do after we expanded our PTV. When we expand our PTV, the PTV is having the whole skin here and encroach upon the ribs and chest wall muscles. So when we have the PTV eval, we just ensure that we have edited margin, first 5 millimeter under the skin posteriorly, should not extend deeper than that from the anterior surface to the rib. And this is used only for DVH constraint analysis. If we can go through sorry. Should I click share again? I mean, you can see the atlas now or not?
Click on the atlas, and when you click share screen.
Okay. 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 Okay, good. So we have this CTV of the breast, and this is breast PTV, which include the whole skin area and includes a part here on the chest wall and ribs. And here is the PTV eval where we edit 5 millimeter from the skin side and making sure that we are not encroached upon the ribs and muscles. Well, actually, when you calculate the dose, you will find that the skin, by having the PTV eval, having the dose that exceeding 90%. But if you don't, the DVH cannot calculate properly what's going on if you are just including the skin with the target itself. You will make disturbance for the system to cover the glandular tissue itself. It's just the physics wise. Maybe if we had a physics colleagues here can tell us more about why we edit or clipping, which we do it every day, clipping for the skin and for the chest wall from this side, what we called PTV eval. Okay. So move on.
So now click back the share screen. And then click on the PowerPoint slides.
Okay.
Eval stands for evaluation.
Okay.
Good question. Let's see. Soha, you clicked on the share screen and you clicked on your PowerPoint?
I did. You didn't see the...
No, try it one more time. Click on the green share screen.
Oh, sorry. Okay.
Perfect. Thank you.
Good. So if we're coming to the lumpectomy, which is very crucial part in contouring the breast tissue, we always use all available information to target the lumpectomy area itself. We have to go through clinical examination and pre-surgical examination, go to the mammograph, where the tumor was, and any clips, incisional scar changes, patient CTs, everything, seroma. So you have to just collect all your information to detect the lumpectomy side very well and not miss it, because this is an area of microscopic cells that has to be covered. So again, when you made up your mind, and this is the lumpectomy area upon the clips from the surgeons and the mammograph site of the tumor previously, and so we just contour the GTV and expand 1 centimeter, and it's 3D expansion in the whole dimension. And this is limited posteriorly again by the surface of pectoralis major and the skin 5 millimeter from front. And this is what we call lumpectomy PTV eval also. Should not cross the midline as a rule. We shouldn't cross the midline. Why that? Because sometimes the mass become very medial. So when you expand sometime, you cross the midline in such an area. So whatever the lumpectomy area is and the expansion of the CTV and PTV, please don't ever cross the midline because you will encroach upon the other breast and increasing the volume of the irradiated lung and heart. This is a very good slide.
And so, sorry, regarding the lumpectomy GTV, do you know why it is that we call it GTV if we don't see tumor?
Well, it depends on the time that you contour this patient. If it is directly post lumpectomy, post-operative, or you met this lady after a course of chemotherapy, or you met her before the chemo and you made up your mind to make this plan or mammograph or CT to make sure that this is the site. Under all circumstances, you have some what we call even tumor shrinked bed. It never fade up because it's a surgery, you know. You have some fibrosis in such a case. You can see something. So it's GTV, you can see it. And also the clips give you what we call an image that the tumor was here, okay? So when you contour it based on what you see. It's not something, that tumor that I removed and I don't have a landmark for it. So the seroma size, this is the issue, is it is having variation during the time, but it never fade up. And even so, when we had no seroma at all, we had some fibrosis or clips. So whenever I can detect the site, so this is the GTV. What do you think? I understand your question that the lump is not there. So why CTV? Why GTV? It is CTV because the lump is not there. But consider it as if the clips is a tool of when I have a brain tumor, for instance, and the tumor is out. And when I'm going to have a fusion and see the tumor again, I call GTV, isn't it? Does it make sense? If you have a fusion for something which is already surgically excised, we call GTV. We don't call it CTV. Did you have the CNS round? Not yet.
Yes. Yes. Yeah. Understood.
You call GTV. You don't call it CTV. because you can see it on the fusion site. So this is here, the clips and the anatomical changes in the area give us a clue that there is something here. Okay.
Very good. Thank you so much.
Yeah. Okay. So this slide, I like it so much. I was lucky person was one of the coordinator of a breast course from ISRO in Egypt, and Dr. Portman was the head of this course. And we have plenty of discussion with this great, nice man in the radiotherapy of the breast. He's the best, I think. He's from Netherlands and working in Belgium. So just to know what's going on here is the colors, those colors. The red one is the tumor, blue dots is macroscopic extension, and the green one is regional microscopic extension, 1.5 centimeter when you have a partial breast irradiation. If you are just boosting, just expand with 1 centimeter. And the blue one is the rim of extension, which is shrinked over the time. This is the rim. Ben, this is the rim which is shrinked over the time. The rim of the seroma is keeping shrinking with the time. And this is the scar, and this is the tumor bed after closure of the lump cavity. And this is the region expected to encompass the tumor bed itself. And this is the CTV, okay? If you come here, this is the tumor where it should be before the surgery. And this is the macroscopic, this is the shrinked rim of excision. And this is my CTV that ensure to include all the microscopic cells around the tumor itself. So here, by time, the rim of the bed is shrinked more, but the theory assumed that the macroscopic cells is there. But let me tell you that there is no perfect plan for the tumor bed whatsoever you did. So there's no one can make sure that the tumor bed that we are delineated, and if you have collect the contouring from the expert all over the world, they will contour it differently according to their seroma and the imaging itself. So my advice is, if you can, to join your surgeon while you are going to contour your tumor bed. This is the best scenario. Following your clips, surgical clips, this is very, very, very important, because the 6 clips is put it on the bottom of the bed, upper, lower, and side by side. So this will be a very useful for covering the tumor bed itself. So, and finally, lumpectomy PTV, which is again 7 millimeter, and it could be less or more according to the center itself. And again, PTV evaluation or PTV eval, which is the edited part of the PTV in order for better DVH constraint analysis and evaluation. Okay. I want to go through in one slide what's simultaneous integrated boost. We go through this term with Shada when we talk about field in field and boosting of a dose or different doses in such a one field. So the simultaneous integrated boost give us a very nice improvement in treatment of the breast cancer, because they decrease the treatment time. Because in concomitant boost or the normal boosting, I finish the 50 gray, let's say if I'm going to give this lady a conventional radiotherapy, then I will give much more 10 gray after I finish. So extending the overall treatment time. When I have the simultaneous integrated boost, I give both of them together. For me, in my center, we practice concomitant boost in the last week. We give 40 gray, and the last week we give simultaneous boost, the whole breast. Then give boosting to the tumor lump in the last week. That's why we decrease the treatment time. And we also decrease the error risk, and it's more comfortable for the boost because the patients is the same positioning, the same site, the same setup, the same DRRs, the same verification. So you decrease much the error of mistake and missing this target. And we decrease the dose to non-boost breast tissue, speeds up the planning and a clearer impression of the dose to the organ at risk, because you calculate the whole case together, the whole case with 60 gray together, the glandular tissue itself and the boosting itself, and see the how this compromise the organ at risk with the whole dose, including the breast tissue and the boosting together. Coming to the heart, which is important part of the delineation, this starts just below the bifurcation of the pulmonary trunk. We start delineation from this side. I'll not go the details of delineation because you had a perfect material for delineation, anything in the world. So you have the atlases, you have e-contouring, you have everything, plenty of materials that will highlight how to contour in best way. It's not an issue to contour. The issue is to know the philosophy of contouring and why I go for that and leave this, and how much I take care of this. And so the tricks is much important than telling you how to contour itself or go through the atlases itself. So here, classically, we just below the bifurcation of the pulmonary trunk into the pulmonary arteries and exclude the pericardial fat. I will go through this CT. This is a pericardium, okay, as we see. And this is what we call the pericardial fat. Can you see it? In this case, it's very clear. It's not always that clear. But if you change the window when you are contouring, you will find it very well to distinguish between the pericardium and pericardial fat. And of course, from patient to patient, the thickness of the pericardial fat is different. But again, in my practice, I contour the myocardium itself, okay? And then contour this pericardial fat. Some schools say that the pericardial fat, including the great vessels, that I'm very cautious and anxious to protect them. So it's not a matter of contouring it to avoid covering it. But when I'm coming to the verification picture, sometimes this shadow makes a noise for me to validate the DRRs or the cone beam CT together. So when I contour this part of the fat, it gives me a very good confidence that I'm really validated the films very well and make my eyes comfortable to see the myocardium very well, okay? Especially in the port films when they are gathering during verification. If we come to why contouring of the breast is necessary, because in the past it's not deep past. It is maybe, let's say, 10 years ago, we just having the CT and asking our physics colleagues to arrange their tange for the breast glandular tissue without any contouring of the breast gland. And they doing it perfectly and nicely. I don't know if you guys having this experience to just having a CT for the breast and just opening up the tange, lateral tange and medial tange without any contouring. So many centers used to do that. And there is an argument against contouring. The old way worked. So why we are going to pass through this all hard work and contouring this and having this. And finally, we just giving 2 tange and that's it. So it is clearly necessary to know that the anatomical landmark become an issue nowadays, and it's different from patients to patients. And again, the innovation of the IMRT, VMAT, protons, and partial breast irradiation So it becomes very easy to miss undefined targets in this sophisticated, limited fields in such a technology. Also, it provides uniformity across the centers, because we face some troubles in Z11 trial, for instance, on definition, what's going on the lymph node, what's the high tang and what's the leveling of the lymph node. So delineating each organ and lymph node level makes us speaking in the same tongue when we are going to pool the data or going to have multicentric analysis or multicentric trial. This will help us to make our data homogeneous. Contouring lumpectomy site and nodes is very essential nowadays to ensure the coverage, particularly in patients with unusually located cavities like medial or deep site. So when I visualize those lumpectomy site and node, this will become a very useful us to make sure that they are well covered and the dose is clearly reached these areas.
And Soha, I think these are excellent points that you bring up. And certainly in your regions, whichever country you're in, eventually you're going to want to have data to share and to publish and report about what your outcomes are. And the only way to know what your outcomes are is to measure what you're doing. So contouring is very helpful for that. And also to the point about knowing where the scar is and seeing that, there was a good question that was brought up, Soha. What if the scar edge extends to the midline? Because I know we've talked a lot about avoiding crossing the midline, but what if the scar goes to the midline?
Well, I have to ask why the scar is crossing the midline. The question is why. So is the breast is in, it's either right or left. The breast is not centralized organ, okay? So why the surgeon make the scar a crossing? Is the mass is that medial in order to expand the scar? In such a case, if the tumor is extremely medial up to encasing the midline, let's say, because he will never cross unless his tumor is encasing the midline. It's never been, okay? So if this the case, so I have to boost this site because it's of course it's contaminated area, and the boost of the lumpectomy area will be a very challenging issue. But it's not usual, of course, because when you have a bilateral organ, it's hard to overcome the breast mastectomy itself with crossing the midline. This is not the usual practice anymore. So I have to refer to the surgeon and ask deeply why your scar is crossing, and don't take it easily. Because if I see the lump on the mammograph centralized, so this is not a scar that I keep an eye on it, you know?
Yeah, I think this is a good point. And so Abdul and Bistun and others, I might recommend talking with the surgeons to let them know that where they do the scar is going to impact how you do the radiation treatment. Because I imagine that maybe the surgeons aren't aware or aren't as knowledgeable about how the radiation technique is. So it's really important that they do the scar only where they need to, or else they're going to create extra radiation for the patient.
Yeah.
Good point.
Any other questions?
There was one other question about the CT contrast for simulation. Is it always used or sometimes used?
I give CT contrast.
Okay.
For the boosting, because as I told you, I need everything to help me to recognize the lumpectomy area. Yeah, it's bright. It's much more brighter when I give contrast. Yes.
Yeah, I think it'll help as starting at first with contrast. If you really get a lot of experience, maybe you can try without contrast, but for starting, it would probably be safest to use contrast.
Yeah.
Good.
Okay, so this is again why contouring is necessary. As we said, in 3D, conformal radiotherapy is still the good standard. If no nodal radiotherapy indication, more complex field arrangement nowadays, so we need contour. If we have a respiratory control, deep inspiration, breath hold, gating, we have to contour. If we have a prone position, like we are going to mention it now, it's very, very important to contour. And again, if we have if you are going to radiate by MRT or VMAT, it's really preferable to have contouring, because you will give a certain part of nodal irradiation, simultaneous integrated boost. So this is very important. Contouring is always important, and standardize the data in every center. So here, just to let you, just to make sure that you are aligned in such a, because nowadays we don't see much. Still in the Middle East, we have a common practice of lymph node excision, but all over the world, and nowadays in Egypt, we move in good steps in sentinel lymph node. So you can find sometimes an excised axilla, just sentinel lymph node, or you can face what we call inadequate breast evacuation, like less than 6 nodes or something like that. So the high TANG is a very useful tool when there is no indication for lymph node irradiation, to make sure that the level of the lymph node, level 1 and level 2, is covered. So the variability defined with no clear nodal coverage specification. Practically speaking, the fields extend to below the humeral head here. Here's what we call the high TANG, okay, and which cover the level 1 and variable amount of level 2. So when you go to the high TANG, you are pretty sure that you cover the whole level 1 lymph node and some extent of the level 2. So care should be taken to make sure that the TANGs are deep enough at the superior extents to cover the nodes, and contouring is highly, extremely essential in such cases. The indication for the high TANG is the lymph node negative in sentinel lymph node when sentinel lymph node is not done. If sentinel is not done and the lymph node negative, so I will go for the high TANG. And if there is a limited evacuation of the axilla, I will go also for the high TANG to cover the whole lymph nodes, okay? Passing through the prone position, because this is an important issue, and I know some centers this has become a common practice. In my center, we treat maybe 15 patients till now with the prone position, because this needs a particular immobilization device in order to make the patients lying down comfortably, because the prone position is not comfort by any means for anybody. So when you choose the prone position, there is an indication. You have to make sure that your patient is comfortable, unless that she will keep moving all the time, okay? And I'm not recommending this for very, very fatty patients, because it's hard to get it comfortable in the table due to the abdominal fat, and difficult to omit the other breast, and plenty of issues that will make the immobilization is not correct or the same each day. And also the patients has to be low risk, because there is no need. I have to choose patients with those who are no need for nodal coverage, because I will be worried about the field matching if there is any supraclav or internal memory indication for the treatment, okay? And if there is any lateral cavity, if the tumor is apart lateralized here, I'll be cautious when I'm going to treat it with the prone position. This will be better to be treated with the supine position in order to make sure that the dose is uniformal at this site, because the lateral approach in prone position will underdose here at the surface area, because when we have the prone position, the separation become less. And this is the beauty of the prone. Why we go to the prone position? Because when you go to the prone position, the separation here is become less. So more uniformity of the dose distribution inside the target. And we can use hypofractionation to those candidates who are not good due to inhomogeneity when they are lying supine, especially fatty breast, or they will have a great toxicity because of the folds that has become very obviously in a fatty patients. Okay, so those are the just to keep an eye on those consideration when you are choosing the patients for the prone position. Okay, and also it is perfect for pulmonary disease patients. When some patients have interstitial pulmonary fibrosis or any autoimmune disease of the lung affecting the lung, and those patients having a very, very high problem and high risk if they are treated even with a small volume of the breast, small volume in the lung with radiation. Okay.
So there's a question about the arm angle that you hold up when you're doing the axillary node radiation. Is it important to have the arm raised, or can you have it lower?
No, it's of course it's important to have arm raised. Some centers raise one arm, and some centers raise both arms. Let's have an agreement that raising arm is very important, because I have a lateral tange and medial tange. So if the arm is beside the patient, the tange, particularly the lateral one, will across the hand of the patient. Okay. Because the lateral tange coming from down, so it will move through the hand of the patient. I have to raise up her hand on the same area of the breast cancer site that I'm going to be treated. So it has to be raised up. This is an agreement to raise both or raise one. This is different from site to site. From center to center. For me, I raised both hands because the stability and detecting the midline in very sharp way is always when you are moving the both limbs on the same position at the same time. When you just try to raise up one hand, you will find your vertebrae is S-shape. If you move your both hands now in front of your head, you will find your vertebrae is straight. Okay. Yeah, that's why. So for me, I like to move both hands of the patients. This gives me a pretty sharp centralization of the vertebrae for the patient, but it should be raised. Yes.
Okay, great. And for the prone breast position with the pendulous breast, is it treated with two lateral fields?
Yes.
Hi, Sulafa, is that a question?
Two lateral, yes, two lateral. And if the tumor is lateralized, lateralized, I don't recommend to have the prone position in such a case, because we will underdose by two lateral, because when you have a two lateral, it's always you centralize the dose, because the dose will be always low at under the skin side. So if the tumor is lateralized or superficial, either to treat it on supine position, or sometimes, but this has to be a very, very, very talented and nice physics with you. you give a different weight tange, or not tange, different weight beam to overcome this low dose in this area. Okay, so giving electron or photon for the boost, it's clearly that electron spare more normal tissue. We know this fact about the electron, but in certain situations we want to use photon, like deeper cavity. When the cavity is deep, like this in this picture, it's better to have a photon, because I want a sharp, clear area here with photon in the posterior border. The electron cannot give me this sharpness of the beam, or the dose will not be sharpened as the photon if I use electron. So it's not recommended to give electron in such a deep tumors. And also it depends on the shape of the tumor. If I have wide tumor like this one, it's not recommended to have electron, because I will have a side dose in this area in order to cover whole this wide area. Okay. A rule in boosting the breast, don't go over 12 MeV by electron by any means. If you go above 12 to cover such a tumor, just use the photon. Don't go for high dose electron, because the cosmetic results and risk of telangiectasia will be very high. So whenever you increase your beam above 12 to cover such a tumor bed, just go for photon. Okay. So what's the time now? We exceeding our time, or still we have a time?
We're exceeding, but I think the talk has been very good so far.
Are you okay? I'm fine. So if you are
let's
fine,
continue. Let's
I will continue. Okay. So very quickly, the second case, which is advanced stage disease, we have 42-year-old woman with T3N1 invasive duct carcinoma of the upper outer quadrants of the left breast. ER/PR HER2 is negative, and biopsy-proven lymph node involvement. Preoperative AC Taxol chemotherapy with a good clinical response. She underwent breast conservative resection with lymph node dissection. Final pathology showed no residual disease in the breast with a 7.5 centimeter tumor bed. The lymph node dissection was inadequate, only 7 lymph nodes, and there was a 7 millimeter deposit of a residual tumor in 1/7 lymph node. So this case is candidate for both breast, boost, and lymph node irradiation. So the adjuvant radiotherapy in advanced stage increases local regional control, and this is proved, and increases the survival, particularly in patients with axillary lymph node metastasis. Post-mastectomy radiotherapy indications is 4 or more axillary lymph node involvement, T3 or above, T4, skin and chest, or stage 3 tumor, positive surgical margin, gross extracapsular extension. Invasion in axilla, gross residual disease, or pectoral muscle facial invasion, inadequate axillary dissection, 6 or less than 10. Some people say less than 10 is inadequate axillary dissection. If you are decided to have axillary dissection, not going to sentinel lymph node. And relative post-mastectomy irradiation is 1 to 3 axillary lymph node involvement. This was a huge debate, and I think it's still, till now, it's a debate for those patients with low risk axillary or low volume axillary involvement with closed surgical margin, 1 millimeter, and multiple primary tumor, multicentricity, not multifocality. So this is a relative indication for post-mastectomy radiotherapy and radiation. So I'm going to go through some different atlases that I shared with you yesterday. We share the RTOG and the RADCOM atlas. Okay. So as we agreed upon that in the past era, that was one size fits all. Nowadays, the everything is becoming different and becoming tailored to individualized for the patients. The RTOG Atlas mainly was for the 3D conformal guideline delineation for breast cancer patients in the past and now. This is what I did in my residency, and RTOG is always the easy access for us to contour not only the breast, many things. Nowadays, we have the RADCOM, this atlas, and this is the RTOG, and this is the RADCOM atlas. So the RADCOM atlas is mainly appear or delivered because of the RADCOM study, which is comparing the proton breast irradiation versus photon and introducing the internal mammary irradiation in the indicated high-risk patients. So if we had just, I will go through not a comparison, but to let you imagine what's the difference between atlases, and you choose according to what you are going to use, the patient risk and the technology that you use in your center. So here is 2 cuts on the same level, and this is the supraclavicular lymph node, the beginning of the supraclav lymph node. So the RTOG is limited in the form of the depth here. It's not deep. If we come to the RAD-ONC Atlas, we will find this site is the supraclav, and here is detected contour to the posterior neck, very detected to the posterior neck. So why that? The philosophy here is the RTOG Atlas is basically made for the 3D radiation. So if you have a beam coming here, radiating the supraclav, the exit dose will cover this whole area. So I don't need to extend it, because if I'm extended here, I will go much more to cover whole those area. So the exit is enough to cover this area that was delineated here in the RADCOM. But the RADCOM is basically for those who are treated with the proton. So the Bragg beak sharp edge with no exit will stop here. So I will radiate this area with the supraclav. And if I need this posterior part, I should contour it. Is it clear? The difference between the atlases? If we come here, this is the area where the supraclav meet the axilla. Okay, so in the RTOG, there is, here is the supraclav, and this is the axilla, and this is the supraclav, and this is a part of the axilla. So in RTOG, there is a gap between lymph nodes. Actually, there is no gap between lymph nodes. They are whole continuous together. But again, here treating with 3D radiotherapy, so I'm not sure that the beam will cover this part. But in RADCOM, or when I use the IMRT or even VMAT proton, the things will be much difficult for me, because I have to determine each site I want to be irradiated, rather than that the beam is not going to go through it. Because even if I'm treating with the VMAT or IMRT, I can compromise my beam to such an area and protecting those apart. Okay, same concept. So here we can find the internal mammary, and this is also the internal mammary site creeping at the edge of the sternum. And we can also find here that in RAD-ONC, there is more invasion for the plan going deeply into creeps of the fat plane here. Okay, this is not the case in the RTOG. RTOG does not go creeping those plans, because here I have a very sharp beam when I use proton therapy. So I have to determine every fat plane and every lymph node that I suspected and I wanted to be covered. He goes to the creeps very, very sharply. Here is not. Okay, so those are the two atlases that we are familiar to use, the RTOG and the red unk. And the third atlas is estro-contouring atlas. I will not go through it in details. It's the same. The estro atlas is same red com. It is very, sorry, here is also those upcoming slides is more about the R2 in the estro atlas. This is supraclav definition in estro atlas. You will find that the estro atlas is very similar to RADCOM and very, very limited differences, but it is the same. And it's used for the fashionable trials that go through the breast radiation through new technology with VMAT or proton therapy. So this is the different definitions of the lymph node regarding the axilla, regarding the leveling. I sent to you the 3 atlases yesterday, so you can go through them and compare what's going on between the 3 atlas. For us, as a center, starting with the 3D, RTOG is more than enough and pretty nice. And this will be a good practice because when we are building up the experience, we should start with the things that is familiar, easy, and accessible. So RTOG is always nice. I know that plenty of definitions nowadays for lymph nodes and the targets, but I just highlighted today why those are appearing because of the different technology in the new trials. That's why we need this. Okay, this is the internal memory. Again, here is the critical area behind the sternum. This is the whole junction of the internal memory. Okay. So do these differences matter between atlases? As I told you, atlases generally concur on based of anatomical locations, but vary with respect to extent of the tissue to be contoured. So the patterns of nodal presentation and recurrence data is relatively limited to inform the optimum volume. Till now, we don't know what's the optimum volume to go deeply in the creeps of the fat that including the whole lymph nodes or just contour as we used to do like the RTOG. Plenty of papers nowadays is comparing the area of failure and comparing the atlases regarding the failure pattern, and there is no consensus that there is any difference between those atlas till now. Okay, so the pattern of nodal presentation and recurrence data is relatively limited to inform the optimum volume. Okay. So which atlas to follow, as I told you, it depends on the technique, it depends on the patient risk, and it depends on the anatomy impact of normal tissue or to the anatomy and the impact of the normal tissue itself. If we are centered that we are depend on the patient risk, high internal memory nodes are the most under contoured in a standard atlas. If there is an indication for internal memory, I will have an eye for what's going on the estro atlas, for instance. But in such a case, if I contoured in this way, I have to know that I should go for IMRT or VMAT technique. It will not be useful if I over sophisticated the contour and finally I will treat it with 3D, okay? And of course, depends on patient anatomy. Patient anatomy in the breast cases play a great role to modulate the case itself and direct it in different directions, because the anatomy is the most important issue to impact for extension and regarding the dose of the heart and lung and normal tissue, and it's very a lot from patients to patients. I will not go through planning. I think Shada is doing a great job in such a case in the previous lectures. I will keep the planning technique reference in your slides. Just moving. We had it before with Shada. And regarding the comorbidity, it's always considered the patient risk for late morbidity. We have a patient's factor and treatment factor. The patient factor, does it have a heart disease, hypertension, obesity, diabetes, smoking, connective tissue disease, or previous radiotherapy, specific anatomy like pectus capitis, the load of the surgery or chemotherapy, systemic anthracyclines and endocrinal trastuzumab, plenty of papers and trials that endorse the summation of the effect of the radiotherapy with such cardiac chemotherapy, increased toxicity like anthracycline, trastuzumab. So left breast or right breast, this is have an issue, deep respiratory breath hold or not. So those all factors affecting the comorbidity using electron beam, like we said, and the risk of telangiectasia. So all that affecting the comorbidity of the patients, we have to keep an eye on it to decrease the toxicity. Finally, our job as a radiation oncologist and physics and all people or technicians who are dealing with the radiotherapy is keeping the balance between target volume coverage and organ at rest strain, and optimize the treatment factors to have the good survival, good outcome with less morbidity and toxicity. And thank you so much.
Thank you so much, Dr. Soha. That was a wonderful lecture. And, you know, we had 50 participants from beginning to end. So that's 50 new people who are going to be doing better for their breast treatments. We have, yes, we if there's just some time, a few questions. One is for the physicists, for the planning. Which beam energy to consider using, 6 MV or 15 MV?
6 or 15
no, just for breast treatment.
So sorry, I didn't understand the question.
Is it better to use 6 MV photons or 15 MV photons for breast?
It depends. It depends. We can use 15. We can use it, but if you want to decrease it depends on the anatomy of the breast itself. There is no better than it depends on the anatomy itself for the chest wall and the breast tissue, in order not to underdose in the lateral sides. Sometimes we use the 15, not to under the lateral sides, because in huge pendulous breast and very concave chest wall, it's hard to having the homogeneity, the dose homogeneity inside the target with the sex, unless you increase the dose for the lung, and this is not a good thing. Yeah.
Okay, great. And I see we have 2 people who have raised their hands, so we'll get to you very shortly. There's one question about bilateral breast. If someone needs bilateral treatment, do we do them both at the same time or 2 separate treatments?
Well, I'm writing a paper nowadays because I have experience in bilateral breast. I have 62 patients. It's a multicentric. It's a multicentric. Well, there is no sharp good answer for this question. Some people treat it one by one, and other centers treat it synchronously, because I go through this issue because I'm writing a paper now. So there is a variation. Some goes synchronously and some goes bilaterally. The 3 patients that I treated myself, I treated on the same time because I treated by the VMAT. So I need to examine the dose distribution between the 2 breasts and make sure about the heart and lung doses on the same setup. Because when you are calculating the dose on the same setup, you have the all contribution on your organ at risk, rather than unlike when you have one by one, the total contribution to the organ at risk will not be that sharp or defined. Yeah.
Okay, I hope that helps, Abdul.
Yeah. Any other? Welcome.
Excellent. Mieda, did you have a question? Mieda Al-Shradi? You can unmute your microphone and speak.
عندي سؤال دكتورة سهى بالهول جلاند بريست تشو قلتي السي تي في زائد
yes هو 7 مللي البي تي في and it's variation. ممكن انتوا يبقى نص، ممكن يبقى 1 سنتيمتر. it's variable according to the fixation tool and your verification tool. It depends. The PTV is different between center. Yeah.
يعني
yes. The PTV is not
البروم بوزيشن بلاننج يعني فالبلاننج yes. شكرا دكتور.
So nowadays, of course, it's mandate to delineate the coronary artery itself, but another series of papers highlight that the myocardium itself, irradiation of the myocardium with the 50 gray, carry out a great toxicity later. So it's not an issue of course, the coronary and the apex of the heart, where the 3 coronary arteries are decussating together in one point, is an issue. But still, the myocardium itself is important to be delineated and protected. For you, as a young doctor, I recommend to delineate both, and this will be a good training for you to contour the myocardium and the vessels. And those are very clear and very well defined in the atlases also. And regarding the dose, we don't have a sharp dose, what should I do? But most of the papers also talk about coronary artery less than 2 gray, less than 2. For me, I considered less than 4 is okay, because when I treat the left breast and some anatomical consideration, that you find that the heart is lying down on the chest wall. It's whole the chest wall. So in such a patients, particularly for the left side, I should treat it with breathe hold technique. When I do that, when I treat it with the breathe hold, I can reach the maximum dose less than 3 gray even. Yeah.
Great. I think we have time for 1 or 2 more questions. There's one question from Dr. Bistoun. It's regarding the internal mammary lymph nodes. Can they be included inside the tangent beams, or when does it need a separate beam?
You can't include it on tangent beam, particularly in the lower part. If we revise the atlas, you will find that the internal mammary, when you go down, particularly the new atlases, the ISRO and the RADCOM. ISRO and RADCOM define the internal mammary in a different way than the RTOG. And when you go down, you will find that some part of the internal mammary is creeping behind the sternum. So if you are going to take it with the tange, you will cross the midline. Okay, can you imagine that? If you open the atlas now and see where is the internal mammary, particularly in the lower part, you will find it behind the sternum. So when you are going to have it with the tange, you will cross the midline. So we have the tange for the breast glandular tissue, and we supplement the internal mammary with a different beam. And this will be very useful to use VMAT and IMRT in such a particular case. What did you do in UCSF?
I haven't done my breast rotation
yet. You didn't? Okay.
I'm the wrong person to ask. But this has been a wonderful lecture. So many people in the audience saying thank you very much. Very nice lecture, very informative. And I can tell that, everyone in this curriculum is really starting to think in 3D. And, breast is one example. We don't have time to go over all the different disease sites, but really use these concepts, how we think about planning, how we think about our targets as you go forward and do a good job with all the different disease sites.
Well, I enjoyed the lecture with you also, and if any had any further questions, you can always email me, and we can keep discussion. And maybe when you have your round in the breast round, you can correct or adding for more information for us. Okay, for the breast. Thank you guys, and have a nice weekend, everybody.